Hi, the following content is for educational purposes only and does not constitute medical advice. If you are a healthcare provider, please consult with your affiliated institution or local ethics committee for ethical guidance related to clinical practice. Thank you.
Hello, Bioengineering 131. This is David and Russ and Module 25. Go for it, David.
Okay, so we wanted to give you a few examples of some of the ethical issues that might arise in particular technologies and how we kind of look at some of those for the uses of wearable and mobile health technologies. So the first example wanted to talk about was some pretty exciting, interesting work around the uses of wearable technology and what are sometimes called assist technologies to help deal with patients who have either mild cognitive impairment or dementia, where the MCI becomes more advanced. And there are a lot of wearable mHealth applications to try and help those kinds of patients. For example, giving them clothing or something that they always have to wear on their wrists that allows GPS for location purposes can be very important, so that they can be located in the event that they're lost and you need to try and find them. There can be fall detectors, so that if they're living at home and they fall, you can find that out and go and help them or send the paramedics if you need to.
Hip fractures are like the beginning of the end for so many elderly. Like once you break your hip, you're chair bound. They often don't do surgery. And so in many ways, being an elderly person is a constant struggle not to break your hip.
Yeah, my mother-in-law, who's demented, it was a relatively good fracture, but she fell and broke her hip, and she was obviously spent some time in a rehab facility. Now she's at home, but she's pretty much housebound for the most part. She's walking some, but
Right.
definitely limited mobility as a result of that, and constantly at increased risk of falling. Once, as you said, when somebody's broken their hip, the chances that they're going to fall again is greatly increased, especially if they've got dementia or MCI, and actually very high 1-year mortality for that patient population.
Yeah.
Patients who are over 80 and have broken hips and have dementia have about between 40 and 70% chance of 1-year mortality. So fall detectors are really important, so that you can try and do something about it. And then there can be also important cognitive assessments with these technologies over time, because it's really important to sort of see the curves and see where people are. One of the things that's sort of insidious about some of these diseases is that transition from MCI to dementia is something that's easy for the families who are seeing them every day to kind of miss exactly how far it has really gone. And so having ways of objectively assessing that and seeing where you have to start to do reassessments about changing plans and management can be really important for using these kinds of technologies.
It's very irritating. So my father suffers from dementia, and we see just what you said. We see his worsening, and then there's some nurse who doesn't even know him who comes in to assess him. And if he's having a good day, they'll say, "Oh no, he doesn't need any more care." And it's like, no, you don't understand. There's been this decline. You got him on a good day, but on average days. And so there really is a huge need for sign of objective measures like this.
Well, and that also shows the problem of the snapshot. So she comes in and right then that's what you're seeing, which is a problem with that snapshot assessment. Whereas if you have continuous data being collected, you can actually do a much better job, especially combined with AI, to really be able to potentially get much better measures of how patients are really doing. So there are obviously ethical issues that have arisen in this in this space. There's some literature on the design of these apps and that way ethics gets incorporated in them. And there's in fact even an overall scientific lit review and thematic analysis of all of the ethical issues that have arisen in this space. Most of them can be put into the same framework that we've been discussing with the different Belmont principles. So when we look at this, like for example, what are some of the specific autonomy issues raised by these technologies? Well, on the one hand, it may actually be autonomy promoting because it allows more independence. My mother-in-law can't be alone. It really shouldn't be alone. Really requires 24-hour caregiver, but she just hated it so much, and she dreads the idea of being in an institution so much. We finally compromised. We had 24-hour care for about 5 or 6 months until she regained some of her mobility after her broken hip. But now she's got a caregiver 12 hours a day, which she still hates, but it's a little bit better. But again, using these assisted technologies and using wearables, you may be able to make it possible for some of these patients to age in place, stay in their homes longer, which is something that many of them highly value, and may help promote their independence and their ability to be, not require caregivers to take care of them as much, and allow them some level of independence, which is autonomy promoting. On the other hand, to be able to get them to use this, many dementia, I don't know about your dad, but my mother-in-law does not believe she's got dementia, even though she's sort of got moderate dementia. She just never understands and believes, and that's true of about 80% of dementia patients. And so because she doesn't think she has any need, it's not going to be possible to use these technologies with her knowing about them, because she thinks she's completely fine. So therefore, in the literature, it's sometimes described as justifiable benevolent deception, and you don't really get consent from those patients. And so that's a trade-off in terms of a loss of autonomy, because they may not have capacity to make informed decisions, and you may be having to engage in deception for their own good. And in fact, the McCoy Center for Ethics on campus, I was involved in a program a year ago, I guess, on deception, and Larissa McFarquhar wrote a nice piece in New Yorker about use of deception and taking care of dementia patients. And there's some interesting literature there claiming, like Agnieszka Jaworska, a philosopher who used to be on the faculty here, has argued that it actually can be autonomy promoting to engage in deception, because there's something sort of broken between the patient's desires for what they have and their ability to actualize them. And if you use deception to actualize their their underlying goals and values, it can actually be autonomy promoting rather than mitigating. So those are all autonomy issues. And then there's privacy issues in this space, right? And there you have to say, on the one hand, uses of these technologies may increase physical privacy, because my mother-in-law is able to stay at home, and that's a good thing for her, and that increases her physical privacy control, that she gets to be there rather than in some kind of congregate facility, a memory facility. But it may lead to a decrease in informational privacy, because we'll have access to some information because of this, and may be monitored, like Russ with your dad.
Yeah. So we have, so my dad, as I said, is kind of in early stages Alzheimer's. So he doesn't need 24-hour care, but he needs 8 to 10 hours of care. And I have a webcam in his apartment. He has a 1-bedroom apartment, and I have this webcam, and I can look in on him at any time. So if my sister wants to call, but it's at night, she might call me and say, "Is dad asleep?" And I can instantly turn on the webcam and say, "Yes, he's asleep. Don't call him," or "No, he's not." I remind him on a regular basis that the camera is there. I say, "Remember, look at that camera." But it is clear to me, what's the phrase? Justifiable benevolent deception. He immediately forgets that it's there. And so I have to use my judgment about how often to use it. I actually tend to mostly use it when I have a specific question about his safety or his sleep-wake status, or when I'm talking to him on the phone. In a funny way, when I'm talking on him on the phone, I want to see what his body language is and whether he's paying attention to me. And so I watch him there, and I feel that that's okay, and it's different from me like creepily watching him with no interaction happening. These are all constructs in my head, right? None of this is like real, but it's kind of the way I've been thinking through this. And of course, I always run it by my siblings as a second check that I haven't gone off the rails.
So this is a nice illustration of these trade-offs in autonomy in this particular population with these technologies. There are also some specific risks and benefits for the technologies. On the one hand, it could enhance the well-being of the patient and even enhance their dignity. But one of the potential side effects, if it turns out that you can manage them without a caregiver as much, that may risk the loss of human contact compared to what the contact they would have if they actually had caregivers. And you can imagine, as these technologies become more widely utilized than they are right now, it may be that we will have less caregivers caring for people in their homes, and that using these technologies instead. And again, that may lead to actually more isolation, less interaction with people.
I think you know that Fei Li in computer science has a big research program to monitor, like, look at my father's camera, but forget about me. Just have an AI system watching for falls, watching for his activity level. But one of the motivations that she points to, and I don't want to speak for her, is that it's not clear we will have the workforce for the aging population to actually have caregivers for everybody. And so she partially justifies this by we're going to need this because there's not enough young people to take care of the aging population, which.
Yeah, yeah. I'm actually an ethics. Mildred and I are both ethics consultants for the project that she and Arnie Milstein are working on with the whole. They have a whole set of these kinds of technologies, both inpatient and outpatient. Yeah, a lot of really interesting issues there. Then there's also justice issues. Who will have access to the technology and the support needed to fully utilize this? Will this create cheaper ways of letting people stay home in less safe situations? Could it wind up being abused? All of those would be issues that would be specific to that technology. And then I'm going to just briefly touch on example 2, because you have a nice article that our colleague Laura Roberts wrote about the uses of these technologies in psychiatry. But I just want to again highlight that when you think about these issues and think about it from an autonomy point of view, and as they raise in their article, when you're thinking about direct to consumer, it's a very interesting dilemma there, because from an autonomy perspective, people can buy whatever they want. And there's this sort of line that you hear a lot in the DTC space, and we hear this in consumer genomics too, which is I should be able to get whatever I want and use whatever I want. But at the same time, there are specific clinical care needs and risks with that. You can't just buy whatever drugs you want. That's why we have physicians as gatekeepers. And so with these apps, which people can buy without any kind of intermediary from their clinicians, that it's not always clear that that's maybe autonomy promoting in one way, but it may not be very good for people and be problematic in terms of issues around beneficence. In addition, from the negative for the autonomy point of view is that confidentiality is likely to be poorly understood in these non-clinical contexts, especially going to be a challenge when you think about the sensitive nature of psychiatric and psychological information, and the fact that this is all being collected. Again, Fitbit, your phone, you just aren't thinking about those as necessarily something that's telling people about your nature of your mental health. And yet there are people actively using those technologies to make assessments about people's mental health on an ongoing basis, both in research and for other purposes.
I like that you're saying confidentially is poorly understood, because I think you meant mostly by the patients, but unfortunately there are also companies that poorly understand confidentiality.
Yeah. So well, because again, they're not signatories. They're not covered entities. So they don't have HIPAA. They don't have to follow HIPAA at all. And then lastly, the risks and benefits that are specific to these applications. The article.
Tell us what the psychiatric. Just remind me, what was the psychiatric intervention that we're using as our example here?
There's actually a suite of them. So some of them, and she actually gives 4 concrete examples, 2 that she thinks are good examples and 2 that are bad examples. So one is one that's being utilized in concert with a psychiatrist to keep track of their symptoms for something that's very helpful and useful for them, to do cognitive behavioral therapy in addition to the drugs that they're being given. And so it's being used successfully to help do home cognitive behavioral therapy when they couldn't get access easily to an in-person therapist, to supplement things being done by their psychiatrist. A negative use of that was a patient with PTSD who was using one of these apps for cognitive behavioral therapy, but mostly it just consisted in writing down all of the traumatic experiences in a journal, which, because they have PTSD, just made their symptoms get worse and worse and worse. So that would be a bad use of that application. So there can be specific harms for specific uses of those technologies that can be challenging, and some of them can be used very much in concert with a therapeutic relationship with a clinician, and some can be used very much in a way that could undermine the therapeutic relationship, and therefore can be potentially harmful to the patient and to the interaction. And again, I say patient because they are a patient. And again, but even though they may not, from the point of view of the company, they're not thinking of them as patients, they're thinking of just as customers or consumers of a technology. And I think that clash which we're seeing more and more with these kind of technologies, these wearables and mobile health technologies at very much at the forefront between these two very different worlds of the medical world that we inhabit, that's very used to thinking of things a certain way, and the computer science world that looks at things very, very differently, and thinking of, patients versus consumers are really fundamentally different ways of looking at those things, and how the people look at themselves. They may not be aware of the fact that they're crossed over into being a patient rather than a consumer, and that carries significant implications. And the company may not know how to handle the fact that they're now dealing with somebody who's really more of a patient than a consumer. And I think that wraps up this video.
Thank you very much. Thank you for coming to Module 25, and this ends Module 25.